I'm pleased to welcome everyone back. Some of you know that we did this last year, so this is like year 2 of having the series. The good news this year is that we are now formally blessed and formally anointed by the Greater University as part of the Greater GWU Seminar Series. I think we're one of 12 seminar series that's blessed across the entire university campuses, not within the school or not within the medical center. So I am pleased to introduce our guest, Ed Salsberg. Ed, actually, for those of you that were not here last year, kicked off the series last year when he was wearing the hat of the director of the Health Workforce Studies group in HRSA. He's now full-time on faculty here with us, and we're pleased to welcome Ed to give us an update on the most recent breaking news about what is or isn't happening with graduate medical education in the country.
As many of you know, the IOM recently issued a report on GME financing and organization. GME has been a really critical issue, health workforce issue, and mired in complexity in part. The nation spends about $15 billion a year to support graduate medical education. It's one of the few areas where the federal government plays a major role in financing. About $10 billion a year through Medicare goes to graduate medical education. The committee spent about 2 years on this issue and really struggled with really fundamental questions. I think going from some folks on the committee who felt, and I wasn't on the committee, but some folks on the committee who felt, why do we have GME, Medicare supporting GME at all, to others who felt that it was an appropriate role and that the federal government should be far more activist in GME. Dr. Fitzhugh Mullen, who couldn't make it today on our faculty, was a member of the committee. The committee's report calls for some important changes in how we finance the graduate medical education. It's interesting because the report, which was issued on July 29th this summer, immediately brought out a very strong reaction from many of the vested interests in the country, the AHA, the AMA, the AAMC, and others who are interested, have an interest in this area. I will tell you, unfortunately, in my opinion, many of the comments were negative, and the vested interest opposed many aspects of this report. So I'm sure we'll continue to hear a debate going forward about the report and how to move forward. Briefly, as background, some of you may know that in 1965, when they passed Medicare for the first time, financing of graduate medical education was included with a very specific provision that this suggestion that this was a temporary financing until the community at large could agree on how the appropriate way to finance graduate medical education. So 50 years later, we're still trying to figure out how do we finance graduate medical education. I will mention, since I know there are folks from the School of Nursing and PA, that one of the questions the committee did struggle with is why just physicians? You know, why is it that physicians get funding for clerkships and graduate training and other professions don't? The committee did struggle with it. There's not a good answer. I mean, I think the real answer is it was a historical accident. And going way back, when Medicare was trying to figure out how much do you pay hospitals, and the medical training was in hospitals, and they said, well, we'll pay for them because it's part of the hospital product. And actually, nursing was included if it was a hospital-based nursing program. As we're now trying to move education of physicians and others away from, or not have it exclusively in major teaching hospitals, tying it to inpatient days becomes problematic. So I'm going to review what the report said and what some of the controversies are that are surrounding the recommendations. I'm going to talk about the physician shortage because, as you'll see, one of the key questions is, do you believe the nation is going to be facing a significant shortage of physicians? And if so, how do the committee recommendations impact on that? So first, some of the key recommendations that my perspective on the workforce aspects. First, they recommended the continuation of the $10 billion for financing. Now, it's important to note that there's been this make-believe that Medicare financing is only financing the Medicare share of graduate medical education. So if basically, in very, very gross terms, if Medicare patients were a third of the patients in a hospital, that conceptually, well, Medicare should pick up a third of the cost of training. Well, it turns out Medicare is the only payer paying that they're the 100% of the costs of training. What the committee said was that let's accept the fact that the $10 billion Medicare is paying is a consistent and ongoing contribution, and let's move it to a separate fund and not tie it to inpatient days. If you were strict interpretation of the statute, and it was interesting at the Health Affairs briefing on the subject, Bruce Laddick spoke, and Bruce, former head of HCFA, what was then HCFA, was expressing concern for the Medicare Trust Fund, like you're not allowed to just take this money and use it for GME. This is for Medicare patients. Well, the fact is, again, it's been for general support for GME for many years. Now, it's important to note that the President and MedPAC and others have recommended a cut in the Medicare GME financing. And as a counter, in part as a counter, but as an alternative, AAMC and AMA and others have proposed bills that would increase GME financing under the belief that the nation's going to face a major physician shortage. So some of the key interest groups say we need more money for GME for more GME positions. The government, federal government, again, MedPAC and the President saying, you know what, we don't need all this money for GME. We can't justify all of this money. So it's interesting because if you really believe that Congress was likely to cut GME financing, then holding GME constant is actually an improvement. If you think politically you could get Congress to increase financing, then holding it constant at $10 billion is a loss. And I think there's a misinterpretation, or that's the wrong term, that the judgment on the part of some of the interest groups that they are likely to get an increase in GME financing is, I think, unlikely, even though there's 150 sponsors to the AAMC-backed bill to increase GME financing. And some of you may have noted in some of the summaries in health policy this week that there was a briefing on Capitol Hill, again, talking about the AAMC-sponsored and co-sponsored, talking about why we need more GME dollars to support an expansion of GME slots, which we need to address the potential shortage. So I think that what the committee did was say, we're going to take a middle road. We're not going to propose new GME funding. We're not proposing a cut in funding. We want to hold the funding constant. And then they said we want to divide the money up. We want to support GME positions, and but we also, in operational, the currently funded positions, but we also want a transformation fund because we think we need to find better ways to train the physicians of the future. The operational fund would do a per resident amount. Again, this is such a arcane area, and several of us, those of us who spent years in the weeds, I remind myself that people don't necessarily know the crazy arcane rules that exist now that some of this is designed to address. Basically Medicare was paying the cost of training. It's a ratio of residents per bed. It's a very complicated formula, and then they froze it in 1997. And so parts of the country aren't getting as much money as other parts of the country. The big winners are the Northeast states in New York and D.C., Massachusetts, and others that had much longer established GME programs than the rest of the nation. So you find an incredible variation in how much Medicare pays per slot. So an operational fund that says we're going to pay a national per resident amount adjusted for regionally for cost of living means that hospitals in New York who get a lot per resident would lose money, and hospitals in California who get a low amount per resident would increase money, would get more money. And so doing the basically flat national amount, which sounds pretty fair, actually, would cause a disruption in the current system. And then, again, they propose 10 to 30% being the transformation funds. And the transformation fund was to cover needed GME slots as well as innovations in education. One of the concepts here is that the GME funds, that $10 billion goes to hospitals at a time when people are trying to move training to ambulatory sites. So you had a very innovative program funded the last 5 years called Teaching Health Centers, which several people here are familiar with since GW has the evaluation contract, where we're saying we want to encourage, particularly primary care, training in community-based sites. So the Transformation Fund would look at new ways to make education more relevant. And one last aspect, the bill would create a new GME Policy Council in the Office of the Secretary, reporting directly to the Secretary to try and elevate the policy discussion. And in many ways, what the committee provided was a framework, was the general structure for decision making and financing, and deferred a lot to this policy council. So questions, why is it that we only fund physician and graduate education, and should we be funding other professions? This committee would struggle with that. This committee would have to define that transformation fund, which would be $1 to $3 billion a year, going to support new needed GME. The council would have to help figure out, how do you know what needed new GME is? So the council would play an important role. In ways it's modeled on MedPAC, just a bit smaller. My perspective of why I think this is a good set of policies for academic medicine, as I mentioned, holding GME constant, which rather than cutting it, it really, another change would be that now all the money goes to the teaching hospital because it's tied to how many inpatient days Medicare patients have in your hospital. This would say money would actually go to the GME program sponsor. Now this is, again, somewhat arcane, like isn't the hospital the sponsor? And in about 2/3 of the cases, the hospital is the GME sponsor, but they're not always. And the GME sponsors may be the program or maybe the medical school. And the ACGME, the Accreditation Commission for Graduate Medical Education, who accredits and oversees graduate medical education, holds the sponsor responsible for the product. So when the ACGME says, we need physicians who are skilled in this area or that area, in HIT or communicable disease or population health, it's the ACGME who is setting the standards. So the concept here was the money should go to the organizational unit that's actually responsible for the quality of the graduate medical education. The fact that they would flow GME funds to the sponsor and detach it from the inpatient days, I view that as a positive. I mean, the fact is we're trying to reduce inpatient days, and I think it's really, in the long term, tying your GME financing to something that you're trying to decrease. It works against that effort to decrease and really is a sort of declining base. I like that it uses a per resident amount. I should mention that the Transformation Fund would support children's graduate medical education and the teaching health centers. You have to understand, again, one of the anomalies of the current system is that teaching children's graduate medical education, pediatrics, and children and pediatric subspecialties, which happens in children's hospitals, have very few Medicare patients. It's not surprising that children's hospitals get very little GME, so Congress responded by doing an annual appropriation for children's GME. And teaching health centers, because they're in community clinics and community health centers for the most part, they also don't have a direct linkage to Medicare inpatient GME. So this this would support teaching in those sites, and it clearly would support innovations in education and training. We've been in a very lockstep process, and people are calling for innovations not only in delivery but also in training. So I think there are three key workforce questions to consider. The first is, are we facing a physician squeeze? Because those arguing against this say we need more money for GME because we're going to have a big physician shortage. I'm sorry, are we facing a physician shortage? The second, are we facing a GME squeeze? The GME squeeze concept is we're increasing medical school graduates faster than GME slots, and therefore will we in fact have U.S. medical school graduates who can't get a GME slot? Very hot political issue. And then the real question of what would the IOM GME recommendations do about this in any case? So the first question, which is again quite controversial, is, are we facing a physician shortage? Now, if you followed this, you'll know that the AAMC report issued first in 2010 said we were going to be facing, actually 2008 and then 2010 updated, that we were going to be facing a major physician shortage. And I can't tell you the number of articles around in the popular press that cite this. And I should be ambivalent about it. Some of you know I was responsible for that report. And now I think there are some shortcomings in that report. So I'm not happy to see that quoted constantly. What that report said is we would be facing a shortage of about 45,000 primary care physicians in 2020. It said we'd be facing a shortage of about 45,500 specialists in 2020, and about 130,000 overall in 2025. A report that got far, far less attention was the HRSA report, which I was also responsible for, which found that if you put in NPs and PAs more explicitly, using more updated numbers with NPs and PAs, the shortage in 2020 was actually no worse than the shortage in 2010. Both methodologies said, let's assume at the start there's a shortage of about 7,500, the number of physicians that would be needed to eliminate the HPSA health professional shortage area designation. And what the HRSA report found is that the shortage, when looked at that way, the shortage in 2020 was actually going to be less than it was in 2010. So obviously a very, very significant difference analytically. And there's a lot of room for debating how you do projections and the methodology and which one is correct. And I will tell you that one of the problems with both of them is they're talking about national shortages. National shortages verge on meaningless because we have such a large, diverse country that you could have a surplus and still have many, many communities with shortages. And so an alternative approach is to look at within communities and add that up. And we know that we have many communities with shortages. So I'm not suggesting there aren't and there won't be many areas of the country needing more, but the question of the justification for a major federal funding for new GME, particularly untargeted GME, is undercut if you don't believe we're facing a major national shortage. And the reasons why I think a major national general shortage are unlikely. Several key reasons. The changing delivery system, and I think, I will tell you, when we did the AAMC report, we had no way of knowing how to build in efforts to improve productivity and efficiency in healthcare. And this was pre-ACA, and we were using 2005, 6, 7 numbers. And now that we have the ACA and I see some of the initiatives and the incredible outburst of efforts nationally to find ways to change the delivery system, I think we have to build this in. And I actually have a lot of confidence in that the efforts will yield positive results. I also think that I didn't build it in, is a specific in this, but the whole idea that you can measure supply on one hand and demand on the other, and then compare them out 5 or 10 or 15 years without having built into the methodology an explicit relationship, interaction between supply and demand is a mistake. The fact is, if you have a shortage on the supply side, that both the existing supply and demand get adjusted. And this thought that that providers, particularly organized providers, large systems, are going to say, oh, I'm sorry, we don't have enough physicians, sorry, we can't serve, people are standing at the door, and they're going to go home, is incorrect. Those providers, if the fiscal incentives are correct, are going to try and find a way to deliver those services. The reality is the physician supply is growing, and while it's not growing as fast as the population, it is growing. And the fact is that NPs and PAs and pharmacists, therapists, nurses, and others are growing rapidly. I actually think telecommunications, telehealth will actually have a positive long-term impact. A lot of room for debate, and I know there's a lot of frustration with it, but I really believe that there's great potential. And then the flexibility and creativity of health providers. Those who are on the academic side and the research side, it's really important that we do a better job with our data in this whole area. You know, if you look at the experience in Massachusetts, where they did expand coverage and say, well, what happened in Massachusetts? You know, some people look at an annual report that comes out by the Mass Medical Society, and you know, they say, oh my God, there's a 30-day wait or 60-day wait for appointment, and you know, the sky is falling, and you know, this expansion of coverage created all these problems. Well, when I look at national data sets, the fact is that we didn't see any change. We looked at the Burfus data and other data sets. We didn't see any decrease in access in Massachusetts. The system does adjust. The other thing, it's also interesting, when you think about what's the impact of the ACA, and ACA did add some demand, but I will tell you, the demand from the ACA was relatively minor compared to the increase in demand from the aging and the growth of the population. And most studies found that the ACA, and this was the studies that we did at HRSA and others, that even if you assume full Medicaid uptake, all 50 states, that the demand for increased demand for primary care was only going to be in the 2 to 3% range. And then there were 3 other studies. Now, I could say, on one hand, we can play with statistics, and I will tell you 2 or 3% is not much, and I really do believe that. On the other hand, if you already believe you're facing a shortage, and then add 2% on demand, that is increasing to the shortage. The fact is that that 2 and 3% increase in demand was pretty well spread out, and it was really the underserved communities that were really going to face a greater problem. But even there, was only talking about, for the most part, a 5 to 10% bump up in demand due to the ACA. And again, if you believe that we have a healthy, creative delivery system, there's no reason to believe that they're not going to work with us to find better ways to deliver services. So my bottom line assumption is, conclusions, that we're not going to be facing a major shortage. Now the question of where is the literature and what are the research studies that are now coming out, and what do they tell us? Again, I get frustrated when the press go back and continue in 2014 to cite a 2010 update that was of a 2008 study that used mid and early 2000 data to say the AAMC says a shortage of 90,000 physicians. There haven't been many new studies. We funded a study at HRSA, but that hasn't been released. The best work actually that's going on now is out of UNC, Chapel Hill, the Sheff Center. They've developed a new model, and a new, really I think more sophisticated model that they've released as a tool. Well, if you run the numbers using that tool, you'll see that there are very few national shortages. There are regional and local shortages. So I'm hopeful that we'll get more published articles with hard numbers. Some of you know there have been a series of articles about this more broadly. Quickly, the numbers, and I've shown these before, the rapid growth of non-physician clinicians. These are NP graduates. These are PA graduates. This particular chart really undercounts the likely growth, because there are now about 120 160 accredited programs.
87.
Now 187 accredited. Last time I looked, there were 160 accredited programs and 65 or more programs seeking approval. So I have another slide, not here, that shows the number of programs. So the fact is there are another 60 or so programs in the pipeline. So the number of PAs, well, if you compare it to the NPs, it looks like NPs are growing more rapidly. They did more than double production over a 12-year period or 10-year period. My guess is what we're going to see is the next surge in the number of PA graduates going forward. I was curious, I also looked at the pharmacy graduates, and they are doubling. And we think pharmacists can play an important role in the delivery system. So a whole range of, and this doesn't even get into an area of community health workers and patient advocates and patient assistants and health educators and care coordinators and others. So really a growth in a whole range of health professions, which when you talk about the adequacy of the supply, may come back to how well do physicians accept the involvement and the increasing role of other practitioners. And the fact is the team, and we keep talking about teams and interprofessional, they have tremendous potential. I've used this slide before. This from the study that Altschuler et al. Had published about 2 years ago in the Annals of Family Medicine, where they looked at how many patients could a family physician serve if they did all the things that recommended for patients, if they were practicing by themselves and if they were practicing in a team. And they said if they don't do any delegation, then you need about one family physician for about 983 patients. But if they really do delegate, and that's not only NPs and PAs, it's medical assistants and others, you could get by with one primary care physician for 1,900. An enormous, enormous range, a twofold different. One, we have a terrible shortage, and the other one, we actually have a surplus. So really, the importance of the potential role of the team in helping us meet our future needs. So many of you know there was a Health Affairs journal dedicated to health workforce in November 2013, and a whole series of articles. I picked out a handful that were most relevant, showing that we are making progress, we are really learning, we are demonstrating that there are other clinicians that can provide important services to the population. Now the question of are we facing a GME squeeze gets to the fact, or gets to the data, that the medical school enrollment is increasing by about 3% per year, and GME slots have been increasing by about 1% per year. Thank you, Bianca. Here's the bottom line. A decade ago, when I was at AAMC, we recommended that U.S. medical school enrollment increase by a third. We were graduating then about 16,000 medical school graduates and I think about 2,000 osteopaths per year. We recommended that by 2015 that we increase by a third. We bring in about 6,000 to 7,000 foreign medical school graduates every year into the GME system. Again, clearly GME is what determines your supply of physicians, because it's not just your medical school. We've historically added about 25% of our physician supply coming from foreign medical schools. So it's really GME that controls the supply, because it's taking US MDs, DOs, and foreign medical school graduates. So there was a concern when we put out figures, AAMC put out figures, which said if we increase US medical school enrollment and osteopathic enrollment by 6,000, 7,000, 8,000 over the next decade, what will happen to someone's going to get squeezed. The fact is that the numbers are growing. 2014, there were about 22,000 medical school seniors, medical and osteopathic, and about 30,000 residency slots. So the fact is there were far more slots than there are graduates. There are only about 2% of the graduates didn't get matched through the NRMP. So the squeeze is, in our projections, is really very limited. And there's some work we're doing with with Fitz Mullen on, that based on our analysis, even the medical school graduates are growing 3%, and GME is only growing at 1% a year. When you get to 2021, there's still going to be room for 3,600 to 4,500 foreign medical school graduates. It's not like, you know, again, as was feared, that we were going to be growing so fast that there would be no room for all of the U.S. graduates. Now, some of this is interesting because some of the problem has to do with the specialty choices of the U.S. graduates. You know, I will tell you that last year there were something like 850 orthopedic positions. Take it back. There were about 750 first-year orthopedic residency positions. Well, 850 U.S. medical school graduates only selected orthopedic surgery. Now, someone's going to get squeezed since there's only 750 positions. And so you say to them, you know, there are positions in other specialties. And really the importance of good counseling. My fear, to tell you, to be honest, was that while you need good counseling, and we've advocated for good counseling, I was worried that some of the interests were scaring medical students in order to generate political support for more GME money. And so, you know, literally scaring 100,000 people that, you know, you may not be able to become a real full-fledged doctor because there may not be enough GME positions. So the medical student associations are all supportive of, hey, we need more GME money because we're going to be squeezed and we don't want to be squeezed out of a GME position. So again, I was feeling that this was being used politically, and it was really unnecessarily scaring a lot of students for political purposes. So we were trying to show, and Fitz and I are working on an article that says, look, there's plenty of room. An interesting question, I get into debates with people who are supporters of foreign medical school graduates, which is the suggestion that every one of the even if they're 28,000 U.S. medical school graduates, are better than every one of the foreign medical school graduates. And we're certainly not saying that. Foreign medical school graduates have an important role to play. What we're saying really is there's an over-reliance on foreign medical school graduates. Some of you may know there was the U.S. was a signatory to the World Health Assembly International Code of Practice on the recruitment of health personnel, which said the 180 countries that signed it said we would have ethical practices around recruitment, and it said both underdeveloped and developed countries need to do a better job at producing the workforce that they need. In medicine, bringing in 25% of our workers was really an outlier. You know, even in nursing, where people know we bring in a lot of Filipino nurses sometimes, even in the bad years, that was between 5 and 10% of our nurse workforce were Filipino or foreign nurses. No other profession is like medicine, where a full 25% were foreign graduates. So medicine is really an outlier, and I think we need to move the medical school production more rapidly as we are, and GME slots more slowly. And I still think we'll have enough. The other point that I try to make to the medical community, medical education community, interesting, another whole set of issues, that by increasing the residency slots now, as they are advocating in the legislation, the main beneficiary aren't those 300 kids who didn't get matched in the NRMP. The main beneficiary, in my opinion, is going to be the several thousand foreign medical school graduates, particularly graduates of the Caribbean for-profit schools. And that's another whole issue. The Caribbean for-profit schools developed, in my opinion, because the U.S. medical schools were not offering enough opportunities. But with the 30% increase in enrollment, or what's likely to be a 35 to 40% increase in enrollment, I think there really are opportunities now for U.S. kids who want to become physicians. The third question is, well, what would the IOM recommendations do about this anyway? And, you know, I think the sort of the suggestion that the IOM recommendations were going to make things worse really was not accurate. The IOM did say $1 to $3 billion would be going into the Transformation Fund, which could support existing programs where there's documented need. Now, I have to be sensitive. I know we have a lot of primary care advocates, and that the reality is sometimes our needs aren't just primary care. And the fact is, if you looked at the tool that the Shep Center developed, in some communities we do need dermatologists, or we do need orthopedic surgeons. There's not a simple national either or yes, you're shortage, or no, you're not. So the idea of targeting based on documentation makes sense to me. And the IOM said they would put money out. The recommendations would lead to new money for expansion. The targeted expansion that the IOM would support, I think, will do more to meet the needs than the alternative supported by the AMA and the AAMC for a much more general GME expansion for the system as a whole. And so I think that, in my opinion, the IO recommendation does a better job at targeting expansion than the alternative, and thus would be better approach to actually meeting the health needs of the nation. So let me conclude with some discussion on the politics of what we heard and what they might have meant. So this is the AAMC press release. In my opinion, really outrageous. These are quotes. I'll admit that the italics are mine. The IOM proposal to radically overhaul graduate medical education and major cuts to patient care. Comment on this. There was no radical overhaul. The whole accreditation system wasn't even touched. No one would change what the ACGME does. No one would tell anyone who they could produce or what they needed to produce. There was nothing changing the true infrastructure for how you do GME. What was changing is who gets paid from the federal government. The major cuts in patient care, which is sort of an interesting argument for the AAMC to make. This wasn't about patient care. GME is supposed to be for medical education and training, not patient care. The wholesale dismantling of our GME system. This is clearly designed to sort of incite the troops to fight harder. And again, I think really reflects their belief that they can get a better deal from Congress to support GME. So what I think they were saying, and this is actually, there are some legitimate challenges and questions. And what I think they were saying was the proposal would do away with the indirect medical education. IME is about $3.5 billion a year. IME, as I say here, mostly supports important things. Teaching hospitals, academic medical centers run 24/7. They run emergency rooms. They run trauma centers. They run a lot of they educate people. They do a lot of good things. The problem that the committee had with the IME is it's totally not linked and it's not accountable. Teaching hospital, there's $3.5 billion. They don't have to show they've done anything. It's not like they say this money went to support this emergency room 24/7 and this trauma center and this burn center. It's you guys do good things. We're going to give you $3.5 billion, and they're saying don't ask us questions. I mean, that's how I interpret this. Now the AAMC's opinion, which I think there's some reasonable concern, is you take $3.5 billion out of teaching hospitals now, you are going to be hurting them, and they are doing these good things. And so maybe it's not it's not transparent where the money is going, but you don't want to undercut our academic medical centers. They could have, I think, made a more persuasive case in saying and targeted their comments more to this. The presentations at the Health Affairs briefing, I mean, it was clear. If you happen to be a teaching health center in a state that expanded Medicaid, then in fact you are likely to be getting money that used to be bad debt and charity care. And so the ACA reduction in bad debt and charity care is being replaced by new coverage. If you're in a state that did not expand Medicaid and you were getting the indirect medical education, you're feeling a double whammy of, now I'm getting less bad debt and charity care, and I'm going to lose my IME money. So there is a legitimate concern. But again, I think the fact is, this is $10 billion is really called graduate medical education. We need a pot of funds to support GME. I think they were also feeling that they can convince Congress to increase money for GME, so holding the money constant was not a positive for them. The fact that the recommendations would flow money to sponsors, and in some cases take the money out of the hands of the teaching hospital and put it into the GME sponsor, would make hospitals very nervous. The fact that they were going to use a per resident amount means that the hospitals in the Northeast are likely to lose money. You know, one of the interesting questions would be, is it likely that we'll have a coalition of hospitals and states that would be the gainers, say, you know what, we're going to gain more out of this? Right now, I think the AHA and AAMC have sort of holding the coalition together. And so we haven't heard yet from states breaking from these other groups and saying, wait a second, and I really would sort of expect places like California and Texas and others, to, and even Florida, to say, states that have been arguing for years that their GME programs are underfunded by Medicare, to say this is an avenue for us to actually get more, address some of our concerns. So there are all sorts of issues in conclusion, lots of issues. There's the analytical issues. Are we having a shortage? There are the issues about how we, whether the system is going to respond or how they're going to respond. There are issues of political positions, political issues as well. My general overview, the current GME system is outdated, inequitable, and has really unintended consequences. And I still think it's unsustainable when we're trying to break down the historical reliance on hospitals. I mean, if we were trying to move care to ambulatory care sites, we're going to need a GME system that's not tied to just inpatient care. I think the GME Commission report is a framework. I mean, it's not a blueprint. There's a lot of details that need to be filled in, but I think it really provides a pathway to a more responsive more responsive system for workforce development. I think there are needs for targeted GME investments, increasing the number of GME slots in education, but they really need to be targeted. By the way, just an interesting side debate is the teaching hospitals in the Northeast, and the existing ones, would argue that, well, yes, maybe you do need to train in ambulatory sites, and you do need more, orthopedic surgeons in rural Nebraska. But we, the big academic medical centers, are the best teachers. We have the most experience, and so why would you want to start another program in a small Midwest community, or Florida that's growing, or Texas that's growing? We're the experts in education. Just have us educate more. Well, you look at where people go after training, and they do travel across country, but there's also a significant percent stay in where they are trained. So the geographical imbalance, we want to address that. We need to be sensitive of the real world of, can we do effective education in dispersed? And contrary to the AAMC, the IOM recommendations would not destroy GME, and I really think strengthen the education aspect of that funding. And I think the goal here of the statements, and this is very consistent with what I said at the Health Affairs briefing, is really to get a dialogue going, and that's why the interest of the organized groups, the response of the organized groups was so discouraging, because it really felt like they were trying to close down any serious discussion about how we finance GME, and we've spent 50 years debating how to finance it, and I think there's a pathway, and I think what we really need is the constructive dialogue, which includes the academic medical centers and the AMA and the AHA at the table to find a more rational approach. The ultimate goal is producing a workforce that meets the nation's needs better. So let me stop there and ask if there are questions.